Welcome to Airway Management Module number 1, Common Artificial Airways that are used for patient ventilation. In this module, we're going to cover oral endotracheal tubes, nasotracheal tubes, LMA airways, tracheostomy tubes, fenestrated tracheostomy tubes, tracheostomy buttons, the Passey-Muir speaking valve, and some common complications associated with artificial airways. If we take a look at your common oral endotracheal tube, you should be able to identify some of the basic markings on the tube. Two of the markings are the IT and the Z79, and those markings indicate that the tube has been implant tested, typically in rabbit muscle tissue for compatibility, and it is in accordance with the National Standards Committee. You'll also see markings on the tube that indicate the length of the tube in terms of where it is in relationship to the lip of the mouth when you intubate someone. And there is a radio-opaque marker on the tube for X-ray detection so that you can see the tube placement. And there is something that's known as the Murphy's eye, which is right here. And the Murphy's eye allows ventilation in the event of obstruction at the end of the tube. Also on the tube is the internal and outer diameters, and that allows you to properly choose the correct size depending on whether it's an adult, a adolescent, or a infant. You'll also take note that the cuff is part of the tube, and you have what's known as a pilot balloon where you inflate the air, and then you should either measure the cuff pressure or use one of the acceptable techniques known as minimal occlusive volume or minimal leak technique to affirm that you have the lowest amount of pressure to seal the cuff. Now, although oral endotracheal tubes are by far the most commonly used tubes, there are times where a nasotracheal tube may be utilized, and there are some possible advantages to that. However, I think the disadvantages outweigh the advantages, and that is why you see oral intubation utilized much more frequently than nasotracheal intubation. There are claims that it's easier to stabilize, it may be better tolerated by the patient, it's harder to extubate, easier to attach equipment, easy to pass a suction catheter, and easy for the patient to drink and communicate not having the tube in their mouth. However, and you can see that some forceps, McGill forceps sometimes are used to help assist with proper placement of the nasotracheal tube, and sometimes a fiber optic bronchoscope is used, especially in the situation of a suspected neck injury where you would not be able to hyperextend the neck. That may be an appropriate situation where you have to do what we refer to as an NT intubation. However, there are complications of nasotracheal tubes that you should be aware of, and typically pressure necrosis of the nasal tissue is a problem. There may be a greater breakdown, and you may not be able to keep the tube in place as long as you would an oral endotracheal tube. Problems with the sinuses, potential middle ear infections, septal deviation may be a problem trying to intubate someone with a nasotracheal tube, and bleeding during intubation. Another step that you should utilize if you are planning on doing a nasotracheal intubation is to apply some kind of topical vasoconstrictor in order to open up the airway and prevent mucosal damage. At one time, cocaine was used as a vasoconstrictor, and it's an excellent vasoconstrictor, but it's often very difficult to obtain legally in many countries, and so drugs, certain types of xylocaines are preferred, or lidocaine preparations prior to the nasal intubation. One last fact is that nasal tubes are about 2 to 3 centimeters longer than an oral tube, because obviously you're starting from a point further away from the carina, so there are tubes that are specifically designed for nasal intubation. The next type of airway is known as the LMA, or laryngeal mask airway. And you can see from the diagram that it has a cuff and a valve and the tube itself and the airway connector. And there are different reasons why a LMA may be used. I would say the primary reason is for short-term ventilatory support, either during a surgical procedure or some type of procedure where you would need to ventilate the airway for only a short period of time. There are some additional items here. It could be because the face mask is difficult to fit, unsuccessful. If they cannot intubate somebody, they may emergency try the LMA instead. Difficult for bag mask ventilation. It may be much easier to place the LMA than to try to ventilate somebody with a mask. And again, for elective surgical procedures, that's typically a common use of the LMA. There are some precautions or contraindications for the LMA, and the first one is somewhat understandable, that you would need to be properly trained in the placement of the LMA, and if you are not properly trained and the LMA is placed improperly, it could result in serious problems for the patient. If the risk of aspiration is very high, then when you place this into the airway, and if the patient should vomit and aspirate, if they have a very strong gag reflex and they're not sedated, then that can be problematic as well. The advantages of the LMA, and you can see from the diagram here how the LMA is actually placed and closes off the esophagus basically to prevent aspiration, but at the same time allows ventilation via the trachea. The airway can be quickly inserted when bag mask ventilation is not adequate. ET intubation cannot be accomplished. Again, if you cannot intubate someone, you're having difficulty, you could place the LMA. You have less gastric insufflation than with the bag mask. No risk of esophageal or bronchial intubation, I would say, with the tube, and less risk of trauma to the airway. Well, as compared to the LMA that we just covered for short-term ventilatory support, we have tracheostomy tubes, which are typically utilized for longer support or patients who are unable to successfully wean from mechanical ventilation. And you can see that the trach tubes are inserted between the second and third tracheal rings, and there is an obturator, which is removed, and an intercannula, which is this device right here, which is inserted. And it also has a cuff and a pilot balloon, which you would inflate and secure. And the picture to the right here shows a common trach setup with the gauze and how the trach is secured with the Velcro straps around the neck. Well, there are some advantages of the tracheostomy tube, even though it seems to be more of a permanent airway. Keep in mind that it still bypasses the upper airway, and however, it avoids some of the problems posed by both oral and nasal endotracheal tubes because, one, it's easier for the person to communicate. They don't have something in their mouth or in their nose. They could eventually start to eat, and it's designed for more long-term ventilatory care. Patients do wean from trachs. Some of them, depending on their underlying condition, may be permanently on a ventilator with a tracheostomy in. So it really depends on the underlying state of the patient, which determines whether or not the trach will eventually come out or remain in. Like all artificial airways, you can imagine that you would possibly develop some type of complications in the situation of a tracheostomy. Pneumothorax is a possibility, bleeding around the site, air embolism, and subcutaneous emphysema. This X-ray actually shows subcutaneous emphysema, and one of the ways you can tell is one thing, this right lung here is very dark, and whenever you have air either in the lung or the subcutaneous space, it looks black. You have a loss of the vascular markings, which is the normal black and white interface, so you can see that. But the subQ also creates linear streaking. And you can see some linear streaking along here. You can also see some linear streaking along the outside here. And that's indicative that you have air trapped in the subcutaneous space. Well, if these are some of the immediate or short-term complications, some of the longer-term complications or late complications that can develop are hemorrhaging, infection, obstruction, either by mucus or bronchospasm distally. And some of the later ones, if the trach is in for a long time, if you're not monitoring the pressures on the tracheal wall, you could develop a tracheal esophageal fistula, which you can see. This is a picture of the fistula and a hole basically into the esophagus communicating with the trachea. Or you could develop stenosis, subglottic stenosis. In this case, the trachea is now narrowed, so you have an increased resistance in the airway. Or you could have tracheitis, which would also be representative of either swelling or narrowing of the airway. Well, we have some special tracheostomy tubes, and they're known as fenestrated trach tubes. And if we're looking at weaning somebody from a trach, we can't always just remove the trach immediately. And similar to weaning somebody from mechanical ventilation, it tends to be a step-by-step process. So in this case, we have a tube that has an additional hole in the posterior portion of the tube, and it'll allow the person to speak, and it'll aid in weaning. The inner cannula can then be removed, and the outer cannula can be plugged, because then they would be able, you can imagine the air will be able to come through here and still go through the trachea, go over the vocal cords, and be inhaled and exhaled throughout the mouth. So this is a first step in getting the person ready to possibly plug the tube with a button and then ultimately remove the tube. The cuff's deflated and air moves through the tube, out the fenestration, and through the patient's mouth, like we can see. You can also see the diagram here as well, what the fenestrated tube does. Well, the next step would be then to, if the fenestrated tube works and the patient can tolerate it, then you would move on to possibly a tracheostomy button, where you would then remove the tube and place the button in to maintain patency of the stoma, and to the point where they can close it through surgery, and then the person would restore back to a normal breathing airway. Looking at the next slide, we have something known as Passey-Muir speaking valves, and the Passey-Muir valves are very unique. They fit onto the 15mm adapter of the trach tube, and the trach tube must be deflated when you use a Passey-Muir valve, and it may be used on trach and ventilator-dependent patients. And you can see the valves come in different colors based on different options that the valve company offers. This one here has a little way to secure it, so it's not as easy for it to come off. And you can see that you place the Passey-Muir valve. It's a one-way valve, which basically allows the patient to breathe in, but then air is forced out upward over the vocal cords, which allows the person to speak. So it improves communication, swallowing, helps to decrease aspiration, and in some ways increases oxygenation and helps with the weaning process. So these valves are actually very handy, especially when you're trying to communicate with individuals or children that have trachs in. It's hard sometimes to read their lips and to understand what they want. And when you place the Passey-Muir valve on there, they're actually able to speak. So again, from a morale standpoint and psychological standpoint, it allows them to speak. Well, one of the things that we should always be cognizant of is the pressure that the cuff could exert on the airway, because any types of excess pressure could result in damage or necrosis to the tracheal wall. And so we typically like to use high volume, low pressure cuffs, and we will either measure the cuff pressure or we will use the minimal leak technique, which would basically allow the minimum amount and a small leak at the end of inspiration, or minimal occluding volume, which is a very similar technique, meaning you would move the air out of the cuff until you heard a leak and then place the air, just enough air back in to seal the leak. That way you know you have the minimum volume in order to seal the cuff without air leaking around it. If you choose to monitor the cuff pressures with a cuff pressure manometer, then ideally keeping the cuff pressure less than 20 millimeters to prevent tracheal wall damage. Anything above 30 obstructs arterial flow. Anything greater than 20 could obstruct venous flow, and greater than 5 could obstruct lymphatic flow. But the benchmark number tends to be keeping the cuff pressure less than 20 millimeters of mercury. So let's look at some of the complications of endotracheal tubes. Typically, patients complain of sore throat, and sometimes on post-extubation they have hoarseness. Occasionally they will develop glottic edema, which may result in mild to moderate stridor. We may incorporate cool aerosol or racemic epinephrine to help reduce the stridor. Sometimes the glottic edema may be marked stridor, and they're unable to maintain the airway, which could result in immediate reintubation. Other complications of ET tubes are sometimes they're poorly tolerated by the conscious to semi-conscious patients. They can be difficult to stabilize, especially if patients are trying to grab at the tube to extubate themselves. The oral secretions, it may require frequent suctioning. Some people feel as though it's gagging them because of the tube and passing down through the back of their throat. It's hard to communicate with them. Trying to talk around the airway makes it very difficult to read their lips. And sometimes patients, when they fight the ventilator, they may bite the tube, which would result in resistance, and if they're on a ventilator, would cause their high pressure alarm to continually go off. Some other complications are subglottic edema, swelling, which we just talked about. However, if the tube is up against the vocal cords, you could have vocal cord ulceration. You could also have vocal cord paralysis post-extubation, and you could have tracheal stenosis, which this scan shows how the trachea has become stenotic, narrowed, or you can have tracheal malacia, which is an actual collapse. The trachea tends to collapse, possibly through loss of vascular structure from pressure of the tube. So these are much more severe ones, stenosis and malacia, and they are more latent ones. Okay, that covers our brief module on airway management, and we'll look forward to seeing you the next time.